let's have a look at the diagnostic interpretation of an arthritis in the shoulder. Well, before we do that, let's go back to the examination. Yeah? Remember, we have 12 tests in our basic examination, and based on the outcome of the test, we're going to determine if the patient has an arthritis, yes or no. So I refer to another film on this learning platform on the shoulder examination, but let's have a quick overview again. So the first test was active arm elevation. Then we did exactly the same in a passive version. You check the end feel, elastic end feel. Make sure you don't miss a painful arc, because the interpretation of a painful arc could be very, very important. Yeah. More important for an arthritis is the glenohumeral abduction. Remember, we block the lower angle of the scapula. We actually try to avoid the 60 degrees of scapular rotation, which happens during an elevation. So we exclude that and we look at the glenohumeral abduction. Passive lateral rotation, passive medial rotation, make sure you really go to the end of the movement. Yeah. And then we continue with resisted test, resisted abduction, adduction, lateral rotation, medial rotation, flexion, and extension. Okay, that was a very quick overview. Again, I refer to the extensive film on examination in another film section. One accessory test, passive horizontal adduction. What is the important element? The important element is the clinical reasoning element. Remember, what is the basics in orthopedic medicine? After finishing the examination, you ask yourself the question, what did we see? Did we see a local lesion or did we see a referred problem? The shoulder pain over here, is it coming from a shoulder lesion or is it coming from the cervical spine? Mostly you have an answer to that question at the end of the history. And once we have a local lesion, then you ask yourself the question, what did we see? A lesion of an inert structure and or a contractile lesion? And if there is a lesion of an inert structure, then you have to ask yourself, okay, capsular pattern or non-capsular pattern? And remember, the interpretation of a capsular pattern means arthrosis, arthritis. A non-capsular pattern is something else. For instance, a bursitis. And the last question we ask ourselves, do we know who is responsible for the problems? Do we know where exactly? Perhaps not. Perhaps we need palpation to have a more specific diagnosis. So this was also the subject of another film on the basics in orthopedic medicine. So let's apply that to the shoulder. What is the capsular pattern in the shoulder? We have a limitation of movement in lateral rotation, more limited than abduction, more limited than medial rotation. It's about the relation of the limitation. Could be a small limitation, could be a medium limitation, could be a big limitation, but lateral rotation is more limited than abduction. Glenohumeral abduction, remember, where we blocked the scapula, and abduction is more limited than medial rotation. So that's a capsular pattern. Remember, capsular pattern with a harder end feel, you think of arthrosis. Capsular pattern with a muscle spasm end feel, you think of arthritis. And now it's going to be very important to determine the stage of an arthritis. And there are 3 questions in the history which are going to be very helpful. You ask the patient, do you have pain at rest? Do you have radiation of pain that goes further than the elbow? And can you lie down on that side? And what do we do with the answers? If you get 3 favorable answers, so I don't have pain at rest, I can lie on that side, I don't have radiation that goes further than the elbow, 3 favorable answers, and you find a capsular pattern with a muscle spasm end feel, then this is going to be an arthritis stage 1. In other words, arthritis light. If you have 3 unfavorable answers, you have pain at rest, you can't lie on that side, you have a lot of radiation of pain, well, then we think of an arthritis stage 3. an arthritis heavy. And any combination, some favorable answer, some unfavorable answer, then you're somewhere in the middle, you're in an arthritis stage 2. Well, this is going to be super important. And why is that super important? Because the treatment of a stage 1 arthritis is totally different than the treatment of a stage 3 arthritis. Not a little bit different, totally different. So we have to keep that in mind, and therefore our patient selection or our diagnostic selection is going to be quite important. We have another little element from the examination which could help. Remember, lateral rotation limited. What could you find? You could find a limitation, and if you try to go further, then you get some muscle spasm. Or it's really painful. Oh, stop. Oh, limitation and muscle spasm. Two different situations. The first situation, okay, first you have the limitation, then you go further, and then you get the painful muscle spasm, is slightly irritated, stage 1. If you have pain, and then stop, don't continue anymore, this is heavily irritated, stage 3. In fact, where is the capsular pattern coming from? Well, in an acute situation, the capsular pattern is more or less a protective mechanism, a protective muscle spasm. In chronic cases, you're going to find, actually the reason is going to be different. You're going to have really a structural problem, a problem with adhesive scar tissue. So you can imagine that the treatment in the acute situation is going to be totally different than the treatment in the chronic situation. What's the clinical image of a traumatic arthritis? Well, there is something particular about the traumatic arthritis, more specifically the age of the patient. You don't expect the traumatic arthritis below the age of 40 years. So we don't expect that in a patient of 25 years old. So we expect that more or less above the age of 40. We don't know why. At this moment, this is still an empirical finding. What's the history of a traumatic arthritis? Well, of course, there was a trauma in the history, or there was some kind of overuse, followed by some pain. But the strange thing is, the pain slowly but surely goes away, and the patient said, okay, everything okay, no problem. And then the next day or in 2 days, the pain is coming back, and then slowly but surely it gets worse and worse again. And then, of course, he goes to the therapist to look for help. Well, there's also some positive news. A traumatic arthritis has a spontaneous evolution in about, let's say, 9 to 12 months. And there are 3 different phases. You have 3 to 4 months, the pain and the limitation of movement is increasing. 3 to 4 months, it's more or less stable. 3 to 4 months, it gets better again. So, the good news is, sooner or later, it will be okay without any treatment. But of course, we're not going to say to the patient, okay, wait another 5 months and it's going to be okay. No, we have an efficient treatment strategy for the patient in every phase. So more good news, when you look at the spontaneous evolution, the pain is the first thing that improves, that gets better. The limitation of movement is the last thing. But it is important to know where exactly we are in this evolution. Remember, I was talking to you about a stage 1, stage 2, stage 3 arthritis. Well, the treatment strategy is going to be quite different. So what is the treatment strategy for a stage 1 arthritis? One movement, or one word, I mean movement. Yeah. Movement. Yeah. We're going to do capsular stretch. intensive capsular stretch. You go to the end of the movement, you go further, it hurts, you stay there for about 30 seconds, you release the tension and you repeat it all over again. And you do capsular stretch in every possible direction. And you do that for about 15 or 20 minutes. You combine that with exercises and specifically also home exercises. So give the patient some homework. He has to keep on moving. There is something particular about this capsular stretch. So it's not a touristic trip, it's not a pleasure trip. It is no pain, no gain. The patient comes to you for the first time, he comes back, let's say in 2 days, and you ask him, tell me, how was your experience after the first treatment? Did you get any after pain? Oh no, didn't feel anything. That's not good. Or the patient who says, well, actually, all night long, I had quite some pain after your treatment. That's also not good, that's too much. So what are we aiming for? We are looking for about 1 to 2 hours after pain. And of course, this is trial and error. I suggest to give the first session 10 minutes of capsular stretch at a certain intensity and just analyze the next treatment. Did you provoke after pain? Didn't you? Too much? Not enough? And based on this information, you're going to increase the intensity of your treatment or you're going to decrease it a little bit. Yeah? But look for this 1 or 2 hours of after pain. So you do that for about 3 times a week. And what do you expect? You expect in about 2 weeks' time that there is a very nice improvement. The treatment strategy of a stage 3 arthritis is totally different. Here I would say no movement. There are 2 options. You have the physio option and you have the option for the doctor. Well, let me start with the physio option. No mobilization, no exercise, it's a stage 3 arthritis, it's too acute, it's too painful. We're going to do the distraction technique. And the distraction technique is in fact a kind of mechanoreceptor technique where you build in a little bit of traction, and under traction you're going to do slight vibrations and change the angle once in a while. It's in fact a very nice pain reducing technique. The patient loves it. Yeah? You do it for about 20 minutes. You see the patient, if possible, every day. And slowly but surely, he's going to evaluate to a stage 2. And in a stage 2, you can already start doing some mobilization technique. How do you know he's in a stage 2? You just listen to the story. You remember those 3 questions. Yeah? But I come back to that a little bit later. Okay? So that's the physio alternative. What is the doctor alternative? Is going to be an intra-articular injection in the joint with corticosteroid. Not one injection, but preferably a series of injections. And this is exactly one of the mistakes we very often see. The patient gets an injection and then the doctor says, well, come back when you feel pain again. Of course the patient is going to come back because one injection certainly is not enough. So he comes back after some time, okay, we give a second injection. Okay, good idea. But it is a better idea to give him a series of injections, 3, 4, 5 injections. Today 1, the next one in 7 days. From those 7 days, the next one in 10 days. You keep the joint under the influence of the medication for some amount of time. And this is more efficient. You lose less time with this approach. And don't be afraid, 3, 4, 5 injections with corticosteroid in the shoulder doesn't have any negative side effect. There's more than enough research on that field. So this is one little element, series of injections. And another element is, let's imagine the patient has a stage 1 arthritis. It's not so severe at that moment. He goes to his therapist. The therapist is examining. And he sees, oh, it's not that much limited, so the patient gets some medication, but of course medication that doesn't give too much effect. The traumatic arthritis is just evaluating, and after some weeks he's in a stage 2, he has more pain, he has more limitation of movement, he goes back to the therapist. The therapist is checking, says, oh yes, there's more limitation, you have to go to the physio, this needs to be mobilized. Good idea. But we should have this idea at day 1 and not 3-4 weeks later. A stage 1 arthritis as soon as possible to the physio. This needs to be mobilized. This is the road to success when it comes to stage 1 arthritis. So keep that in mind. This is quite important. Yeah? Okay. Again, I would like to emphasize, when you do the capsular stretch, aim for some after pain. Okay. Well, to summarize the strategy, if you have a stage 1 arthritis, you have 3 favorable answers. Remember, can you lie on that side? Do you have radiation below the elbow? And is there any pain at rest? You have 0 unfavorable answers. What are we going to do? As I just illustrated, you're going to do capsular stretch, exercise, movement. If you have a stage 2 minus, you have 2 favorable answers and 1 unfavorable answer, then you have to be careful with intensive stretch. Do end range mobilization first before you try stretch. When you have a stage 2 plus, you have 1 favorable answer and 2 unfavorable answers. You mobilize, but when it's too acute, you have to do distraction technique. It's a little bit in between. Yeah, because the stage 3, as you know, no mobilization, no exercise, just the distraction technique 4 or 5 times a week, or the series of intra-articular injections. So stage 1, that's very obvious. Stage 3, that's very obvious. Here, you have to work according to the irritability of the lesion. Just make sure you don't hurt him too much. Okay, so that's going to be your therapy guideline for arthritis. Traumatic arthritis was a very popular option. There are some other options. Immobilizational arthritis, for instance. This is something we should try to avoid. Let's imagine the patient got elbow surgery and he got immobilized for some time, and the patient is 55 years old. If we forget in the revalidation process to do some shoulder movement, he's going to develop an immobilization arthritis. So that's something we should avoid. This could also be a complication after shoulder surgery. So that's not always that easy. Another type of arthritis is the more steroid-sensitive arthritis. And what's the difference between a traumatic arthritis and the so-called steroid-sensitive arthritis? Well, in the traumatic arthritis, you have a story. There is a trauma, there is an overuse. In this type of arthritis, you don't have a story. If you ask to the patient, how did it start? Then the patient says, I don't know. It just fell from the sky. I woke up with it this morning. There's no direct link. Reacts very well on a series of intra-articular injections. Yeah? Stage 3, of course. Yeah? In stage 1, you're going to do the manual treatment again. We are all aware of a frozen shoulder, yeah? But frozen shoulder is also an arthritis image, but as you know, perhaps with a link with diabetic patients, with heart patients, with other problems, perhaps it's a bilateral problem. One little detail, if the diabetic patient is insulin dependent, then let's say the treatment prognosis for his shoulder arthritis, for his frozen shoulder, is less optimal. But anyhow, he needs movement. Those are physio patients. Yeah? But perhaps you will need a little bit more time to restore his function. Other option. Rheumatoid arthritis, simple arthrosis, and then some complications as a bacterial arthritis, for instance. So if you summarize, actually the traumatic arthritis with the story and the steroid sensitive arthritis without, let's say, provoking factors, yeah, without overuse, without trauma, those are the most frequent ones. So my advice is that you certainly focus on determining, is it a stage 1, a 2 or a 3, and that you adapt your treatment plan accordingly. So have fun with your arthritis discovery. We reach the end of range and stretch for about 45 seconds. We relax and stretch again. For more patient comfort, we can also incorporate vibrations in the stretched position. This technique can be used in stage 1 arthritis. The distraction technique used in the third stage of an arthritis is a pain inhibition technique without the purpose of mobilizing. Under slight traction, hardly visible vibrations are given for about 20 minutes. The patient's shoulder is kept in a comfortable position to be able to work without the slightest pain. In order to prevent adaptation of the nervous cells, minute changes are constantly built in. The patient lies prone on the couch, his arm by his side, his elbow flexed 90 degrees and his forearm under his abdomen. The thumb is put on the point where the acromion and the spine of the scapula meet at straight angles. The index finger is put on the coracoid process. The line joining both fingers crosses the glenoid cavity. The needle is thrust in just underneath the thumb, aimed at a point just lateral to the coracoid process. The first resistance is felt when piercing the capsule of the joint, a second one on impingement against the articular cartilage. Now the intra-articular injection is given.